Right, just make sure we are recording. Yeah, cool. Right then, evening everyone. Welcome to the next instalment in the Scott Lens webinars. So we've got Scott Brown back again, and this time it's corneal topography, so the ups and downs of corneal topography. So for those of you who are fitting more complex lenses or want to learn a little bit more about what you need to do in terms of topography and how to get the best out of topographers and how it relates to complex lens fitting, ortho-K lenses, etc., night lenses, then you're going to learn a lot today. So as always with the webinars, we've got a certificate code to share with you at the end. So we'll put a link in the chat, and we'll also put a QR code up on the screen. So at the end of the lecture, just scan the QR code or click on the link in the chat, and then we'll get the certificates out to you through that. We've also got questions and answers function available, so either in the Q&A function at the top of the screen or just in the normal chat function. Any questions that you've got at any point during the talk, just pop them in the chat, and then Scott will answer them at the end. But we've also got Pauline on as well from Scotland, so she'll be able to reply to some of them as well and answer a few questions. But we'll do a roundup of all the questions at the end, so everyone gets to hear all the answers to those. So without further ado then, I'll hand you over to Scott. Over to you, Scott.
Great, thank you, and thanks for giving up another evening for another lecture. Hopefully going to make this one interesting. I'm just going to get cracking straight away because I've got, as usual, I've got too many slides, and so I'm just going to rattle through them and hopefully make this interesting. I've got the title wrong. Pauline says it's the ups and downs of corneal topography. There we go. So first mistake of the night, that's it out of the way. So for those of you who don't know me, I'm Scott Brown. I'm an orthokeratologist and optometrist. I qualified, I was quite lucky from the point of view when I qualified in 2004 that I went into practice that was doing specialist contact lenses. We had topography, we were doing orthokeratology, and that's really where so I've been kind of following topography throughout my career from the point of view of fitting. And I find it really invaluable and really insightful, and hopefully I can convey that to you guys tonight. Because a lot of people just think, well, why would I get a topographer? Of all the things that I get these funny, colourful images that don't really seem to link up between what I'm seeing on the screen and actually dealing with my patients. So hopefully tonight I'm going to convince you otherwise. Big ticket items here. So this is really what I think you should understand from topography is, one, that we need to have topography to provide young patients with appropriate standard of care. So this is just basic standard of care now, that we should be doing topography on all patients. From my perspective, topography has opened up specialist contact lens fitting, keratoconics, orthokeratology, the most rewarding part of my career, and from both my perspective and also from patients. So patients love, are really appreciative of that kind of lens fitting. And if we all kind of embrace this, then we get a chance to hopefully grow the industry from our practices and take it forward. And hopefully I'll show you as to why that is. So there's obviously CPD learning objectives, but the ones I really want you to take away from tonight is I want you to see the benefit of patients, and I'm going to run through patient examples. So hopefully on individual cases, you'll see how valuable topography can be. I also want to go back to just talk about the cornea, because we've kind of forgotten a little bit about what the cornea is from the point of view of, or how valuable knowing stuff about the cornea is. And then understand the benefits that we can provide to patients. So big ticket items. And again, what am I looking at? What are these funny pictures? So I've just got lots of things popping up on my screen. Let me just get rid of that. So, and now my screen stopped working. There we go. So we get all these different colourful images. And actually all these are different mathematical ways of looking at a shape. So when we do a corneal topography, this is what we get. We get a shape. That shape does not change. We can make it look lots of different colors. We can put different Zernica polynomials or aberrations. We can extract all that information from it, have the different plots, whether it's tangential or axial elevation. But actually nothing ever changes from this shape that we've got. And that's a really important thing to remember. But for me, topography is always about comparison. So we might be comparing the cornea to what normal would be, or to what a lens fit's going to be, or if we're looking at the tear film from second 1 post-blink versus second 15 post-blink, or are we just isolating the epithelium, which is what we do with orthokeratology? Do we want to see if there's stromal change for somebody developing keratoconus? Are we looking at the eye? It's always about comparing something, and that's how valuable topography is. So let's go back and look at the cornea and have a little bit of a review. So our cornea, when we're doing corneal topography, we're actually measuring the tear film that sits on top of the cornea. And that's a fairly uniform thickness, about 3 to 5 microns thick. So that's even across the whole cornea, so we don't need to worry too much about that. We've then got the layer of the corneal epithelium on top. Now, every contact lens that we fit will alter the corneal epithelium. It's 50 microns on average thick. And then underneath that, we've got the stroma. And the stroma, of course, gives the cornea its structure. It gives it its power and its shape. And the stroma effectively should only change in keratoconus. And it can be changed, which is what we do with keratomileusis. Now, keratomileusis is, so we call orthokeratology, but in actual fact, a really good term to use is night lenses because patients get that. Keratomileusis is laser eye surgery. So the surgeons cottoned on to the idea that this complicated word wasn't good for patient communication. Right. So that's what our cornea is. And it's about 45 diopters in power, so about as powerful as a magnifying loupe. So really, really powerful. It's the most powerful lens in the visual system. So it makes sense that the cornea should stabilize quite early in life. If it didn't stabilize, then the rest of the eye is going to have to catch up to this constantly changing, powerful lens. But it does. It stabilizes very young. So by about the age of 4, we have developed a fully sized cornea. And then from 4 years on and after, that cornea does not change. So the graph on the left here, you can see the lines are all horizontal. So from age 6 to age 15, these horizontal lines, or the ones that are about slant, are only kind of 0.05 of a millimeter. So the cornea doesn't change from this young age at the point that we are seeing patients starting to come into practice. So that means that if we've got a measurement of the cornea, it's going to be valuable for them in 5 or 10 or 20 years' time. So this baseline measurement is valuable to get. And then with topography, or even thinking back to keratometry values were usually always the same year after year, and topography does it much more accurately. We can see year after year. So I'm going to talk about these plots later on, but top left, we've got the first map, the baseline map that we've taken for this patient. Bottom left, we've got a map that was taken 14 years later, and then we've got a subtractive map on the right-hand side, green meaning that there's zero change. So there's no change in this patient's cornea, and that's what we would expect. So because the cornea is stable, this is a really important lesson from this, contact lens fits should never change. So if we've done a good job at the start of fitting, then we shouldn't expect that to change. And for orthokeratologists, this means that we should never need to do a washout, because if we're going to do a washout of a lens, we're only ever going to wash back out to that baseline map. But also think about what we're taught, or what gets taught about soft contact lens fits. We're kind of taught to check a push-up test, which is the fit, the kind of artificial fit of the lens at every test, every contact lens aftercare we do. And is that really a good use of our time? If the cornea is never going to change and the lens fit hasn't changed, surely the push-up test is going to be the same as it was the last time. So could we use this information differently in practice? Again, if the cornea, which is the lens in the eye, is stable, then we shouldn't get any refractive change that's coming from the cornea either. So we'll see axial length increasing in the younger age if we've got myopia, and that's where the change comes from. Or in later life, we should only have, again, if the cornea is stable, then any refractive change should be coming from the lens, the lenticular components to it. And if we've got this baseline, then we've got the ability to then screen patients for disease, namely keratoconus, but also in older patients we might want to compare or see if we see a change that might be to do with Fuchs, or it might be that they've had their cataracts done and there's been a bit of a scar or relaxation of the cornea, and again we could compare to know how much of that corneal change has happened. So the metrics that we apply to the cornea are, well, usually these ones. So keratometry, and we should kind of know in our heads that 780 is the average, the mean K, and the normal range is from sort of 7.5 up to 8.10. It's useful to know that in our heads so that if we're fitting a contact lens and we look at the contact lens and think, oh, this lens isn't very appropriately fitting, or it's moving a bit more than the manufacturer suggests it does, if we've got the keratometry, then we know, oh, this patient's got a really steep eye, a really flat eye. So they're not average, therefore the lens fit might not be an average fit. Is it still tolerable? Then yes or no, we need to make up a lens. And HVID, again, 11.8 is the kind of mean value, and normal variations from about 11.4 to 12.2. Knowing that is useful. So again, if we measure a really small cornea, we think, oh, we might get a slightly unexpected result if we're fitting the patient. Now, a really useful thing, and this is useful in osteal practice, is eyes tend to be very symmetrical. So I think the studies show astigmatism can vary a little bit, but the symmetry between eyes is usually about 0.1 of a millimeter between flat K and also between HVID between eyes. So this is useful in hospital if you've got a patient that's come in and they've maybe had an ulcer in the centre of their cornea, so of course you can't get reliable readings from them. You know that eye probably started with values that were similar to the other eye, so you can base your starting point from the point of view of the other eye. So that's useful information to know. And of course, topographers give us this immediately. As soon as we look at the topography, it's going to tell us the Ks super accurately to decimal points, and we're also going to be able to measure very accurately the HVID. Quite often I get maps through where the HVID is shown on the topographer as maybe in this case 11.6 millimeter, and then the practitioner will say, oh, the cornea is 12.4, and it's been measured with a ruler, the old-fashioned way, which is just kind of ridiculous. So go with your topographer; they're always going to be more accurate. And why do we measure Ks and HVID? Well, again, it's this comparison. We're comparing against the anticipation of a lens fit, and it probably would have been gas perm contact lenses that we're thinking about the fit. So we're going to have that baseline shape, and then we're going to apply a contact lens. Now, even these diagrams here, so if we look at the lens fit on the left, the flat meridian, that's the kind of optimum tear film. The graph on the right-hand side, now, of course, it makes it look like the lens is the wonky bit going up and down, but it's not. It's the cornea, the graph at the bottom. The line at the bottom of the graph is the wonky bit. So that's why we've got the lens fit. The lens is mathematically perfect, and the cornea deviates away from the lens, giving us this minus tear lens. And that's why a corneal gas perm lens that's spherical on a toric cornea would neutralize the tears, neutralize that minus astigmatism. So we'd be comparing Ks and HVID to an anticipated lens fit, whether it's gas perms or whether it's soft lenses. Of course, very few of us now are doing gas perms. So is Ks really that valuable a measurement to be taking? So here we have a patient, age 11 through to age 15. We can see that they've got no prescription to speak of, and acuities and vision and acuities are normal. And we've got normal Ks. There's very little difference between these Ks. So is Ks relevant for this patient? Well, not really when we compare it to the topography that corresponds with this patient. So we can see with this that clearly on year 2, when this patient is 13 years old, that they are developing keratoconus. At this point now, they would be referred for cross-linking, which would stabilise that, which would mean that they would maintain that level of vision and that cornea effectively for the rest of their life. 2008, cross-linking wasn't available, so this patient went on to progress. But this shows the significance of topography, where we're getting the whole view of the cornea rather than just this one metric. Now, that patient would then have gone on to develop one of these patterns, so topography can give us a bit of a different insight as to what type of, what pattern of keratoconus the patient has, whether it's a small cone central or whether it's more peripheral or larger cone, or down to a very peripheral area like pellucid. Effectively, the etiology of these is all the same. The stroma with this is thinning, so the epithelial will be normal, the tear film is normal, but in keratoconus it's the stroma that changes, and so this change would be effectively the same happening just in different parts of the patient's cornea, which is why we get the different patterns. So there's actually some more useful information that we can get from topography that's far more sensitive. That if we're going to bother to measure something about the cornea, we're probably better to measure this. And the first one is K max. So you can see the scale, the number at the top right-hand corner. So that's 44.49 diopters. And the arrow is pointing towards the steepest point of the cornea. So the topographer automatically picks up where the cornea is at its steepest, and it tells you that's the power or the radius. Power and radius are the same at that one point. So Kmax is valuable. I'll show you why in a second. And the other one is the contours, the displacement of the cornea. So if you look at this where I put the dotted green line, you can see that that's matching up with the orange to yellow contour, and it's not right on the visual axis. There's a little bit of displacement there. And there's some figures that go along with that displacement, which are the disease indices. So we've got these 3 green squares in this case. Green because there's no indication of disease, so it's a traffic light system. But this is what the numbers actually mean. So on the left-hand side, we've got the IS value. So, of course, in keratoconus, you tend to get the inferior cornea having a more positive value. So it's the inferior steep power difference. We've got a regular cornea there. The middle one, we've got the SAI, which is where we're looking then at the diagonal power difference. And you can see that this patient, so they've got fairly normal IS value, but the SAI is showing up as a red traffic light system. And then the other one that we've got is the surface regularity index. And again, you can see here, it measures at a different way around a 5 mil circle. So we've got these 3 things. So looking at these 3 the topographer would indicate with the traffic light system, oh, we've got something going on with this, this cornea is unusual. all topographers kind of do maybe different ways of doing it, but they all have a similar way where they tend to give you a report or a readout. And if we look at how sensitive these values are, so this is the same patient, and as you can see, I've now gone through with this patient through to age 23. Unfortunately, at age 23, their vision is 630 and their best corrected acuity is 619. They need to wear specialist contact lenses to get any better acuity than that. But if we look at the Kmax value, you can see it's shifted almost 2 doctors just in the first year. And the SAI and the disease indices have gone red and orange very, very quickly in this patient's journey, where the Ks, the measurement we were kind of looking at with patients, is still very stable and regular. So these indices are very sensitive. If we see a patient where we think we've got a traffic light or we've got a warning for potential disease, all we need to do is wait 6 months and then redo, and after 6 months, if there's going to be progression there, it will show up as confirmed progression. Maybe that they've just got a wonky cornea, but if it's progressive, then that's when we want to refer them for a keratoconus. And keratoconus is a preventable condition. So when I qualified, patients got keratoconus, there was nothing that we could do. We just had to manage them as best as we could. But because of corneal crystalline, it's now preventable. So you can see the Kmax values on this study here. So from year 1, where it's 56.6, and if you compare that to 55, which is actually slightly less in year 5, so the patients show no progression. So corneal cross-linking is considered to stop the progression of keratoconus. And I think it's been available. At one point, I heard that every health board was offering it from 2018. Of course, the system is not perfect. There's patients that get missed. There's patients that it's not accessible for. But from our point of view, the duty of care that we've got, as long as we have referred into the NHS, then we have passed on that responsibility from ourselves from a point of screening. But we want to screen patients as best as we can. Now, keratoconus has a prevalence of 1.5%. Now, it varies a little bit, and some populations have got maybe 4 or 5%. But that's the same prevalence as patients under 64 years of age with glaucoma. So most optometrists would consider it neglectful if you didn't screen a 40-year-old patient as part of your routine examination for glaucoma, either with fields or pressures or doing something like that. But at the same time, we're not screening these young patients, all under 30, where they're going to have a lifelong visual issue for this condition. So this is something that has changed in optometry since I qualified, and the fact that keratoconus has moved from being something that can be managed to something that can actually be prevented. So we now need, from a point of view of screening, need to catch up with that. So if you've got a topographer, use it more, especially on your young patients from the point of view of screening. If you haven't got a topographer, think about doing as much as you can to pick up keratoconus, whether it's RET, whether it's Ks, whatever you can. Because this is a kind of all too common a situation. So this is a patient that eventually ended up with me for contact lens fitting, but they'd been seen in their kind of normal optometrist between 2016 and 2018. They had just been monitored and the specs had been updated as they needed to. I think the specs had been updated kind of once or twice in that period of time with a change in prescription. They didn't really use the specs much because they didn't really make a huge difference to the patient. Eventually, the patient was then referred in 2018. 2019, they went into the NHS system. The NHS took their baseline topography, which they then need to follow up 6 months later to make sure there is progression and justifying the treatment. Of course, unfortunately for this patient, that was 2019, COVID hit, which delayed the follow-up for the patient. But you can see the impact that it has on the patient's vision, where they've gone from having a best corrected spec acuity of 6.9 to 6.19 with specs, and now they have to wear contact lenses. So these patients, now this patient was already keratoconic and showing up. They probably would have been detected if they'd had routine topography done. They probably been detected even before 2016, where they still had good acuity. So these are the patients that we don't want to fail anymore. So baseline topography, this first capture that we want to get as good a capture as we can. Now, of course, our crudest topography is our keratometer. Some of us will have that and nothing else in practice, in which case we still want to get the information as best as we can. But if you look at the size of the capture that we've got with keratometry, we tend to get that with either measured autorefractor auto-Ks, or that's the old-fashioned B&L style. In the middle, we've got topography from a large Placido disc topographer. So that's the ones that tend to have the kind of black and white rings. It's about 1 foot across. And although the Placido rings are quite big, it actually only ever captures about a 6 or 7 mil capture area. And then on the right, we've got a capture from the Medment, which is a small cone topographer. So the Medment and the Keratron are both small cones, so they come very close to the eye, and they tend to give a bigger capture of real data. And when we've got a capture, well, we want the capture to be like the one we've got on the left-hand side. We've got a nice full open eye where we've got this colourful pickup pattern over as big an area as possible. We don't want to have, like we see in the middle, where we've got tear film anomaly there, where there's hot colours beside cold colours. We should never have that on a regular eye. And that's actually the same eye as the left-hand image, taken just a fraction of a second apart. And the topographer scores, topographers usually give you a quality score when you do the capture. They were both good quality scores, but you can see we've got these artifacts in the middle one, so we would discard that image. And then, of course, patients have to have their eyes open for us to get decent amount of information. You don't want to have lids and lashes in the way, as we see in the right-hand image. So having the patient turn the head slightly, open their eye wide is the best way to get a good capture. This is from a different instrument. And again, you can see the impact of having the eye being a little bit closed. So that the image on the right, the fact that the eye is closed means the whole area of the capture gets smaller because the topographer just can't capture that area. So eye needs to be open really wide. And a bit the same with this one. You can see the image on the right again, the lid's slightly closed. It's going to impair the readings. And here it's not the eye that's so much high, there's a heavy brow on this patient. And this can be, if you get this brow effect, that's when you want the patient to reach around and lift not their eyelid like they're putting in a contact lens doing an INR, because that can might dent their globe and alter the result. But if they just pull on their brow or pull down on their cheek, it can help to lift the lids out of the way so we get this really as big a capture as we can. So baseline is the most important map that we're going to take because, one, I've said it before, I'll say it again, it should never change. It should last the patient for the whole of their life, the values we've got, which means we never need to do a washout. We're also going to compare every other map against that baseline. And the baseline is going to give us the information that we use for lens designs or referrals. So that's why it's so important we get this baseline. And to get a baseline, well, every contact lens causes distortion on the epithelium. So ideally, we want to have no contact lens wear on the day of capture. And if you're going to fit something like an ortho-K night lens, then you want to ideally have the patient out of soft lenses for about a week beforehand. So you're getting a really good baseline on. If we get a good baseline, it means that we save our chair time down the line, so it's more effective for us. So I'm kind of school of hard knocks, no contact lenses for a week, so I've got good information so that my chair time is protected going forward. Doing the capture, if your topographer doesn't capture automatically, you want to capture between 1 and 4 seconds post-blink. That's when the tear film's at its most even and least likely to have any distortions. Patients that come in with really long false eyelashes on may compromise the value of the information you're getting too much. And again, you can get them to pull their cheek down or their bare finger. Now, a bit of insight from me as a lab, because this is what a topography is. So effectively, when we get sent or we export a topography and the raw information from a topographer, this is the information we get. Now, this is nothing more than a coordinate and a height. So we see the raw data. We then put this in our own software in order to put a contact lens onto it. So in this case, you can see that we've got the map, the cornea, which is the irregular surface, and we're then going to fit a mathematically perfect lens onto that wonky cornea effectively. And this is a simulation of the lens fit. So we can see there, if you look at the graph at the bottom, in fact, if I make that a bit bigger, you can see the amount of distortion that we're measuring. So we've got this, again, the lens that appears to be going up and down is not, it's spherical. The cornea is actually the thing that's moving away from the contact lens. And in this case, we've got fairly regular astigmatism. So we've got about 20 microns of standoff in one meridian compared to the other meridian. So with a night lens, that would be enough that we would go with a toric lens. So if we drop a toric onto that eye, you can see that we've got now alignment where the lens is aligning with the cornea in the mid-periphery all the way around, and there's just a little wiggle. The other thing to notice is you'll see that the tear lens is more minus in the steep meridian than it is in the flat meridian, and that's how orthokeratoly neutralizes the astigmatism because of this tear lens. The other thing to notice if you look at the lens figures is the alignment curves, so the curves that are out in the periphery are almost identical, 810 and 809 with this patient. And actually the astigmatism is quite central, so it's just the reverse zone on this lens that's toric effectively, the peripheral curves. And this is why we want to measure for night lenses, we want to measure as big an area as possible because this lens is 11 mil in size. And topographers all kind of tell you, you kind of assume they're all going to be the same, they're all going to be as accurate as one another, and they're not. So this is even a difference between the different plots that the Medment has. Now the Medment is probably the most accurate. We've got a single central capture on the left, and we've got what Medment recommends you do, which is a composite map on the right-hand side. Now we don't like composite maps because what tends to happen is you might have you're going to make a composite of joining up 3 or 4 different maps. You might have 2 of those maps are perfect and 1 or 2 are not quite perfect. And when you composite them, what you tend to do is you actually make a less perfect map than you had from 1 of your or 2 of your originals. So the central fixation, one, it's easier to do with the patient, it takes less time. You get enough information from the point of view of designing any corneal lens, and it's also more accurate. Looking at the lens design that we're going to get from this, the numbers at the top, you see there's very little difference between these numbers. It is enough to affect the outcome slightly with a night lens, which is more accurate, but that's the accuracy. So that's the insight that we get. And all that happens from the point of view of when we're talking about night lenses, ortho-K, you just send the maps to the lab. We're then going to customize that lens to fit, and what happens is we'll get a really high success rate. So over the last 2,050 consecutive fits that we did, we got a 92% successful fit rate with ortho-K. Now it varies quite a lot between practices, and this is quite interesting, something I'm trying to look into more. So the top practices, you can see there the patients versus the dropout rate. So 3 practices there, 1 fitted 39, 1 fitted 68, 1 fitted 68, all with very little dropout, 0%, 1%, 3%. And then we've got other practices, again, fitted lots of patients, 60 patients with a 23% dropout, 48 patients with a 29% dropout. Now, this is post LASIK, this is high prescriptions, this is everything thrown into the mix. It's not the kind of, these aren't all the kind of ideal patients that we should be fitting, but there's definitely differences in success rate between different practices. So some of it's down to familiarity, some of it's down to how speculative they are. So I've got quite a high fitting success, but I'm also quite intolerant to patients that I know are going to take up more chair time. So I wouldn't tend to fit the higher, more complex patients. I would just give them a different lens that's more appropriate for them. Whereas other practices tend to go for the more extreme patients. So that's part of the reason why we see this variation between practices. Right, now we get down to trying to understand a little bit of the science behind it. So I said before at the start, there's lots of different ways of looking at the topography. So what we're interested in from the point of view of contact lens fitting is basically 2 maps, tangential and axial. And axial is sometimes called sagittal, sometimes it's called refractive, but these are the 2 maps that we're interested in. And my cauliflower is the best I could come up with in explaining this. So tangential looks at every single point that it's measured and treats it as an individual point. So if we look at that cauliflower, we can see all the little indentations and on the florets of that cauliflower. So that's tangential. And you can see the map underneath. The contours on the color map are quite irregular, they're wiggly. And if we compare that to axial, well, we've wrapped that cauliflower in cling film, so we've put a mathematical sphere over that because the rays of light we know are going to go through the visual axis. So what we're doing is we're making all that rough texture thing into a lens, and it smooths out the contours and gives us the power of the cornea. So we think about tangential, we're thinking about shape. When we think about axial, we're thinking about power. And of course, the cornea is a powerful lens. So we use tangential from the point of screening. That's going to pick up tear film anomalies or irregularities in the cornea and highlight that really well. We then have the corneal metrics that I've mentioned before, and I'm going to talk a bit more about again, where we look at the numbers to make sure that, one, we've got consistent numbers between different topographies, and also are we dealing with an average patient or an unusual patient. And then we've got axial, and this is where we zoom in on the patient's cornea. We've got a normal patient, we're going to zoom in on them to see a bit more in depth and the power and how the power represents. So here we can see we've got a bit of astigmatism, we've got a figure of 8 pattern, and there's a slight inferior skew to this patient with their astigmatism. And this is what it would show up on the measurement. The oculus does very similar. You can see that we've got this figure of 8 pattern with the oculus. This is the SBM, and again, there's lots of different maps there, but we're really just interested in this case, the tangential, and then we'll look at axial afterwards. So what makes a good candidate? So what makes a good candidate for orthokeratology also means what is an average patient. So we've got a map, and in this case, we've got the metrics that go with that patient. So the first thing, I've spoken about it already, we've got their Ks. Still valuable. There is other information that's more valuable potentially, but Ks, we know that this patient's got fairly regular size Ks, and also more importantly, did the Ks match the spec prescription? Because if this Ks and spec prescription don't match, we're probably going to get a different result. And then we've got this K max value and the disease indices to establish, are we dealing with a healthy cornea? We've got our HVID, and the other thing that's very useful about topographers is they quite often tell you where the middle of the iris is. So of course, most patients' visual axis is not in the middle of their cornea. So if you think about a multifocal soft contact lens, it tends to sit on the middle of the cornea. And if your patient has a large angle alpha, the visual axis will not be through the middle of the lens, so the multifocal optics get skewed, and that's why we quite often get poorer quality results with one patient, but we don't with another patient. So the iris center, and then goes hand in hand with the disease indices, but the displacement of the cornea, it influences the fit of the contact lens as well. And some of the topographers, you can put a displacement tool on, where you draw a contour around, a bit like drawing on an iris, but you draw it over the yellow contour there, and it tells you the displacement. So in this patient's got a very low displacement of 0.24 of a millimeter. So let's have a look at a patient who we're going to fit, and they're going to wear night lenses and be an ortho-K patient. So their Ks are nice and steep. They've got steep Ks. Now, steeper Ks means that you should be able to correct a little bit more in power. Flat Ks means that you're going to struggle to correct higher prescription powers. So this patient's got fairly steep Ks. E value, I'm not a huge I don't pay a huge amount of attention to E value because it tends to vary quite a lot between different topographers. So effectively you get used to using your E value with your topographer, but from a point of view of comparing topographers or other people talking about E value, it's not always that relevant. We've got our delta K, our HVID and our iris center are very low figures, as is our corneal displacement. So this is a really average symmetrical patient, a really good patient for going for ortho-K, and just as well because this patient is one of these patients that's a high myope, so they've got over 6.5 diopters of correction. Treatment zone center, good acuity, nice big treatment zone. Now, of course, I should say that this is all because the nocturnal lenses, which are the best ortho-K lenses in the world, give this kind of correction for patients, but this patient that's minus 6.5, you might get another patient that's minus 6.5 and you don't get a good correction, or they get an induced astigmatism. It's because the baseline cornea is not as good. So this baseline assessment is useful. So we do tangential, establish are we dealing with a normal patient? We look at the metrics to make sure the numbers look fairly average, and then we zoom in using the axial to see are we going to anticipate any treatments on decentration. So let's talk about, I said all topography is about comparison, so let's look at some review topographies. So we're going to do reviews obviously for orthokeratology. We're also going to do reviews for keratoconic detection, dry eye and soft lens powers. So most of our patients, as I've said, should not have any change with their cornea. So this is the example I showed you earlier on. So 14 years different, there's no change with this patient. So we can use this to confirm if they have a prescription change. Okay, you're developing a cataract, it's causing lenticular change with your prescription, it's not corneal. But most patients are going to fall into this category. The next one is another one of these keratoconic patients. And again, if we look at so we're doing the subtractive map. So top is the baseline, or the first map that we had, the next one, and then we've got the power difference. Now you can see if we look at the power difference on the right hand side, we click the cursor on the red hotspot there, we've got a power difference of 1.7 diopters. So the referral for cross-linking, the criteria for referral for this change in my area is 0.75 diopters. So this is beyond the criteria for change for referring for cross-linking. But again, if you look at the spec prescription, it's gone from plus 0.75 with a bit of a cell to plus 1.25 with a bit of a cell. Not really much change there indicated with the specs, and the same with the Ks. The Ks are both fairly symmetrical. So we wouldn't pick this up if we're just looking at Ks and spec prescription. This is why we need to be screening patients for keratoconus. This is a patient that's been detected, then had cross-linking, and then we're following them up afterwards. They've had their cross-linking. Again, we can see that the cross-linking has been successful. We've got a green map on the right-hand side showing that there's no change. So this is what the kind of outcome that we're after for patients. Let's look into it in a little bit more in depth. Now, what we're going to do here, this is an ortho-K case. So what we're doing is we're looking at the review map, but we're taking away the baseline. And that means that we're taking away the stroma and the tear film. The tear film is going to be the same in both. The stroma is going to be the same in both. So this highlights just the epithelial cell change that we've changed in order to create a treatment zone. And this is why with ortho-K, you have to do a review map. If you just look at the post-wear map, all you're doing is looking at a kind of funny shaped cornea. You have to remove the baseline information from it, so we see just the epithelial cell change that we've got in order to give us the treatment zone information. So it's classed as a B-A or a subtractive map, or sometimes comparison maps. The topographers call them different ways. All topographers have this function for doing it, and it's the most essential function from the point of view. So there we go. A and B, we're going to take the information away. So we've got a treatment zone. What's the next important thing? Well, the scale that we're looking at. So how much change have we got? So this rainbow color at the side, you can see the scale goes from the bluest color in the middle there, which is 2.5 diopters. So we've got a 2.5 diopter treatment zone power change for this patient. And we've also got, of course, we've built up the epithelial cells in thickness in the periphery. So we've got a power change out in the periphery. You can see that that's it's gone up to about plus 250 in the peripheral power change. Now, if we look at the visual axis, and that's where I put the little black and white cross, you see the treatment zone is not right on that visual axis. Would you agree it's a little bit decentered off to the left? But if we look at the baseline map and we look at the contours of the baseline, we look at the yellow and green contours, we can see that they are also decentered to the left. So when we put a lens on the eye, the patient's going to close their eye. That lens is not going to sit off center. It's going to even itself up so that the contours that it's sitting on are the same on both sides. So the treatment zone effectively will be in the position that we expect from the baseline map. Next thing we're looking at is inside the treatment zone. There's blue. If we've got bluer in the middle and then less blue on the outside, and we've got this nice smooth power in the center of the treatment zone. That shows us that the lens is sitting perfectly in the middle with a perfect amount of a gap. So we don't touch the middle of the cornea, we have a perfect gap there, around about 10 microns thick, and that power change means that we've got a perfect fit. So in this case, we've got a perfect fitting lens, fits in the periphery, and the alignment zone fits in the middle, but you can see the treatment zone is decentered away. So we've given the patient a distance center multifocal cornea that's slightly off center. Now, these colors are all super bright and colorful and they're very exaggerated. Of course, we've got to remember what we're doing is we're literally changing the epithelial cells by about 20 microns in thickness. So topography is so accurate, it's highlighting this tiny, tiny change where we build up the cells in the periphery and thin them very slightly in the middle. So this off-center multifocal distance center cornea that we've given patients the treatment zone, I'm going to give a bit of explanation of 20 happy. So here we have a prescription for a patient. And patient, their right eye, minus 0.25, minus 0.75, 6 minus with that eye, and then corrected down to 6.5. The other eye is a plano, minus 150. So a little bit of a prescription, but this patient is 20 happy without correction. They don't need to wear glasses for distance, computer, or near, and they have an occasional pair of glasses that they use for driving and driving at night. Now, this is my prescription, and I'm actually more than 20 happy. I'm 20 delighted because I'm presbyopic, and I'm still having the freedom of not having to wear contact lenses, specs for reading or for distance. So I'm enjoying the freedom of not having this. So this is the 20 happy that we're looking for with patients, where we don't necessarily collect them to plano, because we've got so used to correcting every patient to plano effectively. So if we have a patient with a -3, -1 axis 35, of course, if we were giving them specs, we would give them specs with that power, -3, -1, -35. And they would have no residual prescription. So they're going to see really crisp and sharp. Everything's going to be great. If we wanted to give them soft contact lenses off the shelf, we wouldn't be able to give them that exact prescription. So we would give them probably the nearest that we could to it. So that would be, we'd give them a -3, -0.75 axis 30, not 35. So that's going to leave them behind a little residual prescription, -0.25 and 5 degrees off with the cil axis. Of course, that patient might actually just be happy with spherical lenses, in which case they'd be happy with a little bit of residual cil like I have. So with orthokeratology in this treatment zone, what we're doing is we're giving patients a multifocal distance center, so they're going to have a bit more residual prescription. So the residual prescription for this patient might be plano with a -0.50 cil. So we see a little bit of reduction with the cil, but we're seeing the fundamental correction of their myopia. And even despite this poorer visual correction than they might get, 7 out of 10 cats or 68 out of 100 humans prefer ortho-K night lens correction over soft day lens contact lenses, which are preferred over specs. So the lifestyle benefits of ortho-K outweigh any of the visual imperfections that they get. So let's look through a case history. So this is a patient, young patient, age 11, about a -250. You can see we've got their treatment zone, which is sitting a little bit low, but again, if we look at the baseline top left, we would expect that. So perfect lens fit, patient is happy, they're 6'6", they're fully corrected. So that's year 1. They come in on year 2, and we measure the power on their cornea on the treatment zone, and they've got the same. They've got power correction on their treatment zone -2.35. Plano, 6'6" correction. A year later, then we go through all the usual stuff when patients come in. How are you getting on with the lenses? Getting on well? Yeah, teenage boys, it's like drawing blood from a stone. 6/12 acuity. That's a bit poorer than it was last time. The other eye was the same, a bit poorer than it was. And their prescription, minus 0.75. Now, of course, 13 years old, already myopic beforehand, and this could be the increase in their myopia. So if that was the case, what we're going to do with a night lens, all you're going to do is you're going to change the minus tear lens that we've got between the cornea and the contact lens. We're going to make it that 0.75 more minus. So the base curve of the contact lens, instead of it would just get a bit flatter, instead of the tear lens being minus 250 in power, it's going to be minus 325 in power. But we did topography, and the topography showed that the power correction this year they were only getting was only 1.82. Now again, I said the cornea should never change. This patient's lens should never change. The nocturnal lenses are super accurate, so the lens is going to be good. So at this point, I then sort of pushed the question a bit more with the patient. So did you definitely wear your lenses last night? This is a Saturday morning appointment. And the patient confesses, no, I didn't wear the lenses last night. So at this point, I knew that the undercorrection was there because they hadn't worn the lenses, although they had said they'd worn the lenses the night before. But the topography was my polygraph test on that day to reveal that they were lying. This patient has then gone on to have more years, and again, you can see they've got a continuously same treatment zone year after year after year. So same power treatment zone. So the cornea doesn't change, the lens doesn't change, the power of the cornea, the treatment zone shouldn't change with these patients, so it should be stable. And this brings us on because this is a patient that's kind of in the age of into myopia control. So we can do a little bit of a customization with myopia control. But we hear about these statistics about myopia control that's 50% effective, but this is a really good graph, I think, that highlights where individual patients were in a study. So you can see what we've got is all of the pale grey dots are the control group, and all of the dark black dots are the ortho-K group. And what you can see is the dark dots are scattered more towards the bottom of the graph, where there's slower increase in axial length. And this plot effectively gave exactly the same statistics. This is an ortho-K study, but it gave almost exactly the same statistics as the MySight study, where they had a similar plot graph as well. So what we see from this is that about 20% of patients that go into myopia control optics are going to stabilize. They're going to get less axial elongation, or equivalent to 1/4 diopter. So they effectively stabilize. So that's the same as that last patient that I just showed you, where they were stable during their teenage years. 90% of the patients fall into the part of the graph where they have had a benefit, but some patients don't get effectively are non-responders. So when we're dealing with a patient, of course, we put them into myopia control. If they're in that 20%, that's great. We're going to get that perfect result where they don't show any progression. But of course, it is normal for some patients to still get progression despite having a myopia control option correcting their vision. So how effective is ortho-K? Well, I'll defer to Mark Bullimore. This is Mark Bullimore, one of the leading ortho myopia experts and experts in myopia control. So he was asked that Cooper vision thing, which is more effective, ortho-K or multifocal contact lenses? And Mark said, well, if we're talking about the current dual focus lens that's MySight, ortho-K wins by no. So effectively, ortho-K, and this was a couple of years ago, ortho-K is as effective as MySight from the point of view of myopia control. Is it the best for your patient? No, that could either be specs, day lenses or night lenses, one of the three, but we've got ortho-K is as effective as MySight from the point of view. What we're starting to see now is, can we take what is already as effective, the standard ortho-K designs, and can we know a bit more about them and alter the treatment? So the treatment zone that I've spoken about, there's two factors about it that can shown to slow down axial length growth. One is how decentered it is, and the other one is how small it is. Now, decentration we can't really control because that's controlled by the shape of the cornea. So that's down to the outcome. But we can control the optic size. Now, we can't make treatment zones bigger. The designs of the manufacturers have all been optimized to give us good quality vision as it can. So we can't make treatment zones bigger, but we can make them smaller. And this is where you can specify a custom lens where you want to have a smaller optic zone. And you can see the smaller optic zone on the lens, where you take the zone size down to maybe a 5mm, causes the topography result to be smaller. It compresses more of those spherical aberrations into the pupil. And this has been shown kind of to improve axial elongation. I say kind of because this is one of the main studies that's quoted, and you can see that at the 2-year point, yes, there is a difference between the 5mm optic and the 6mm optic group. But the graph lines are fairly parallel other than in the first 6 months. So this suggests that you should possibly put a patient into a 5mm optic for 6 months, and then you may as well move them and give them better quality vision, a bigger treatment zone after that And this is not a kind of result that corresponds with normal myopia control. So the Cooper Vision study, for example, with my sight showed that there was a gradual change every single year. I think even by year 7, they were still showing an 18% difference or something like that. So it doesn't make sense that it all happens in the first 6 months. So these are generally fairly small studies. The information on this is still to be kind of properly established from the point of view of, do we need to compromise the vision of the patient, which is the risk of making the treatment zone small with them. Okay. I'm not going to go into too much detail. There's a video tutorial. This is the slides going to be in your handouts, and there's a video tutorial you can click on that goes through. I go through a full explanation of this with patient examples of how you can actually measure spherical aberration, which is one of the things that topographers can do if you want to confirm that you're getting an increase in spherical aberration. Of course, spherical aberration increases if you have a small treatment zone that is decentered. So actually we not look at the two things, we can just look at the one figure that gets spat out effectively. But we look at what is effectively the add, so the difference in the treatment zone in the middle to the edge, called the myopic defocus dose. And this, but like I said, I'm not going to go into this in great depth here. I'll leave that for a more specific talk. And topography is all about comparison, so let's look at a very short-term comparison. If we're looking at taking measurements of the tear film, most of the topographers will also give us a dry eye assessment. So this is the one that comes with the amendment, where we do a 15-second capture, and we look at the tear breakup of that patient over 15 seconds. Now we've got the pretty moving colourful picture, which is the one that the patient's ooh and ah over. The graph at the bottom is actually what I prefer using. What the graph is showing us is where we've got time along the bottom, so 15 seconds. So the patient has to be able to stare for 15 seconds. That in itself is an indication that they've got a dry eye if they can't. And then the other axis is the area of breakup that we've got. So you can see this graph over 15 seconds goes up to about the 50% mark. So 50% of the cornea has tear breakup on it. And then we've got some metrics, some numbers. So if we've got a tear breakup less than 12.1, or we've got a score of greater than 0.1, then this indicates dry eye disease. And the module that's in the amendment has been compared against tear osmolarity, concluding that it's sensitive and specific against this. So it's comparable to doing tear osmolarity. So it is a valuable tool to use. So how would we use this in practice? Well, here's a patient example. So if first of all, we've got a non-contact lens wearing, non-dry eye suffering patient. They should have a graph like we see on the left. So no breakup over the 15-second blink period, and that's what we're seeing there. The graph's flat at the bottom. With a dry eye sufferer, you can see that over the 15 seconds, the graph gradually increases to the point that they've got nearly 50% of breakup. They're symptomatic, they find the discomfort. So we give them eye drop. So in this case, I put in 0.3 Lacrofresh, and you can see that, of course, 1 minute after they've had the super duper drop in, they would have a perfect tear film, which they do. So they've got perfect tear film. If we then do that after 1 hour, we can see that they've still got a very good tear film. And then after 4.5 hours, they've still got a very good tear film. Starting to break up, not be as smooth, but definitely still pretty good. And 4 hours is the time that I'm looking for drops to work with patients. Because if they put the drops in at 8, 12, 4, and 8, that effectively gives them from 8 in the morning until midnight with an effective tear thickness there. Now this patient was slightly perturbed with putting in eye drops. They really didn't like putting in eye drops, so we actually did the same thing with them using the iLogic, the lid sprays, and you see that the lid sprays with this patient were just as effective, so they actually preferred to go with the lid sprays rather than eye drops, just for ease of application. Topographers sometimes also have other functions on them, so just a very quick deviation. We've got usually imagery, whether it's fluorescein or meibomian glands, so this is from the amendment, it does both, but here's an interesting example where photography is very useful. So of course, if we look at a cornea, it should be like the one we've got on the left-hand side, nice and clear, no staining. Patient on the right has got dry eye disease, they've got significant staining, and you can see that their eyes are very, very closed. The patient came in saying, look, I can't see properly, the lids were covering their pupil, and they had already previously, years before, had a lid lift. They wouldn't now consider it again because they were worried that they might get exposure keratopathy. So the patient is now in a position where their eyelids aren't open wide enough. They're not seeing properly. The hospital can't do anything. They were already being diligent with their drops. They were using Hycosan Extra 4 times a day. They were using Vismed, the really greasy one. I can't get it now. Anyway, at night, and they had good lid hygiene. So diligent with their care and their drops, and still in a very unfortunate position. So we tried something with them, and you can see that, and this has also been long-standing. So this was their eyes in 2012 versus 2016. introduced the new treatment in 2016, and by October, this is what their eyes looked like. So their eyes now are wider open. You can see, they can see properly, and the surface of their eyes is looking much better. And then that continued, and it continues right through to now. This patient is still getting the benefits of this treatment. And what was introduced for this patient was omega-3 supplementation. So a really good example of showing this. Now, actually, the photography is probably more useful for justifying why patients are not getting a benefit as they are getting showing the patients that get a benefit. So I've used this photography. I always use this if I put patients onto omega-3 to confirm that there is an improvement, and the cost of being on the omega-3 is going to give them some improvement. So like I say, I've ruled it out the other way. And we can also use the tear film breakup for optimizing every contact lens. So here's a patient wearing an AccuView Oasis lens, again over 15 seconds up to about 50 or 60%, and that's after 2 hours wear. Of course, at the end of the day, after 7 hours wear, the area is much more broken up right from immediately post-blink. We put a drop into their eye. After 1 minute, tear film is perfect. After 15 minutes, we're back to baseline. So wetting drops don't give you long-lasting wettability with contact lenses. So tried the patient with various different lens types, and you can see of these different lens options that we had, the best one is for this patient is the AccuView Moist, which had the lowest amount of breakup after 2 hours wear. But discomfort meant that we will remove the contact lens, we remove the problem, so they went into nocturnal, and they now have, of course, not wearing a contact lens during the day, they have a normal, non-dry related tear film, so they get the benefits of having that. So at the start, I said, why do you need a topographer? So hopefully you remember this slide where I showed that the kind of refraction and Ks are effectively a little bit inappropriate from the point of view of what we should be screening for, and we should now be starting to think about screening all of our young patients for topography for standard of care. And these slides that I showed you where 68% of patients prefer ortho-K, and I showed you the patient example where they got years of benefits. And then from the point of view of growing the industry, well, it's not all bad news thinking about having to go and buy a topographer, because if we look at where things are going over the next 30 years or over the next 25 years now, effectively we're going to go from having 17 million myopes in the UK to having to accommodate a further 15 million myopes, so almost double this provision that we've got just now. So optometry is at a point where it's growing over the next wee while. If we look at those myopes, well, 55% of them would be suitable for perfect prescription effectively for a candidate for ortho-K. So the market that's out there is absolutely massive. And if we look at the public awareness, it's around about less than 1% of the public know about this night lens option they've got. So they have specs, day lenses or night lenses. And if we were to tolerate that into the size of the market, the monetary size of the market, then every practice would effectively be able to generate nearly £500,000. So investment in topographer doesn't need to be that daunting from the point of view of if we look forward as to where things are going. And of course, everyone likes to say, oh, we started a new marketing campaign, it was super successful, but we're just starting to approach a point with a lot of practices that are night lens fitting practices, and they're doing ortho-K where they're just starting to get this natural growth, because we've gone from the innovators through the early adopters. We're now starting to hit that point where the market just starts to take off and the early majority kick in. And that's kind of where we're starting to see it, and that's where the numbers that we're seeing as a manufacturing lab are happening, where we're seeing steady exponential growth effectively of manufacturing. Good, so that's us finished. If you've got any questions, then email, or you want any advice on how to get fitting, then email support@scotlands.com, and either Pauline or myself will pick up the inquiry, and we'll go through the questions that we've got just now. We've got another, if you're interested from the point of view of fitting, we've got a webinar in about 2 or 3 weeks' time, which will be going through to night lens fitting. I'll hand you back to Stuart just now to do his housekeeping.
Lovely, thank you, Scott. See, I told you you'd be able to make topography interesting, so it's fascinating. So I think one of the things with stuff like topography, because like I say, it's not something that a lot of people are doing a lot of at the minute, so it's quite interesting to see what data you can get, really. So we have got a few questions coming in. I think you may have answered one because it was about dry eyes. So what happens if someone has severe dry eye? Is the same measurement taken? So I think that was quite early on in the presentation, so you might have covered that.
So if somebody's got severe dry eye, it can impact on the quality of the topography, but that in itself so for example, the patient that I showed at the end there with the omega-3 supplementation, the first captures that I had of them was only 4. She could only hold her eye open for about 4 seconds. So I knew there was an improvement the second time I saw her when she was managing to hold her eye open for 10 seconds. So it still wasn't enough to get the kind of full data capture for the dry eye module to kick in, but I could see that there was an improvement there. As a general rule, you don't need to put drops in order to get good topography. Most of the topographers will get reasonably good topography, even in a dry eye patient. In actual fact, you don't want to put drops in because it tends to make the eye a bit too moist. You end up with a big lacrimal lake kind of reflection at the bottom and all the rest of it.
Oh, perfect. How does corneal scarring impact on it? Because I suppose if you've got a patient who's maybe had an issue with soft lenses, maybe had a bit of MK or something like that, and want to switch to like a night lens, how would that corneal scarring impact on the measurements?
So topographers tend to build their image from the middle out. So peripheral ulcers aren't usually going to, most of the topographers aren't even going to pick up on them. The Medment will probably pick up on them right at the very edge. But if they've got central scarring, then it tends to throw off the reading. You're not going to fit, you're probably going to fit a gas perm lens that's got apical clearance fit, considerable apical clearance fit on a scarred cornea, because you want that tear lens to then neutralize the irregularity of the cornea. And that's where we rely on that information that this patient started off with symmetrical eyes. So if you've got the unscarred eye and they've had a laceration on their cornea, and you're not getting good information, you're going to say, well, their cornea in the left eye is a 770, so I'm going to start by putting in a lens that should fit that 770 and then assess it. Scarring from ulcers tends to, I've forgotten what is it, necrotic. So ulcers tend to nibble away the stromal tissue. So if you've had a scar on a cornea that's come from an infection, there tends to be less corneal matter there, versus where if you've got a scar from a laceration, that's where you can have raised corneal surface. So it can depend a little bit on the cause as to what you're expecting that you're going to fit.
Excellent, perfect. Is there a minimum diameter topography scan required for night lens fitting?
No. So designing the lenses, actually, we can design a lens very accurately just from Ks. What you need to have from the point of view of the topography function is you need to be able to do that subtractive map. If you can do that subtractive map, because that's going to isolate the epithelial cells, which is what we're changing, then effectively your topographer is suitable for doing it. How good it is and how easy the maps are to interpret is a different story. But what I would always say to somebody is if you've got a topographer, get started, get a few fits, because you will just see the patients just love it so much, and it's so rewarding to do as a practice. So the statistic that I put up there, the 68% of patients prefer that. So if you think about that in spec terms, varifocals are more expensive to fit. They need probably more specialist measurements. They're more expensive to the patient. But patients prefer wearing varifocals to 2 pairs of glasses or to bifocals. And night lenses is the equivalent in the contact lens world from the point of view of it's not offering ortho K and night lenses to patients would be like being in a practice that said, no, we don't fit varifocals. We only offer 2 pairs or bifocals. Mm-hmm. So what I would say is get started. You'll find it so rewarding to do professionally yourself. The patients that you fit will love it. That you can then say, actually, okay, well, the topographer that I've got is not ideal. I'm going to get a better topographer that's more suitable for that application. But if you've got one that you can use, just get started and then improve once you've established the market. If you're thinking of buying one, and of course BCLA is next week. If you're thinking of buying one, I would say definitely go and speak to Bib. The Medment, from my perspective, I've seen the raw data, is the best on the market, head and shoulders from the point of view of accuracy, fit, ease, speed of use as well in practice. And they don't pay me to say that. That's just an honest opinion. To save you time in practice,
They should pay you, definitely. So, if the cornea is stable at such a young age, would you consider fitting ortho-K to very young children?
Yes. So, we need the myopia to kick in. And again, we need the myopia to be the vanilla myopes. So we don't want to be, for your 5-year-old patient that's already a -8, that's pathological myopia. We want to manage that pathology, not really be too concerned about the myopia control element of that. But from the point of view of patients, so I've fitted from 5, and 5 is a fairly common age for practitioners to be fitting. It's quite good at that point. Young kids are actually quite diligent with their care and all the rest of it. It's the teens that tend to get a bit more grotty. But young kids, they're much more open to their parents being a bit involved. So the 5-year-old that I fitted, he held his lids apart and looked down, and then the mum popped the lens on, and then the mum would take the lens out in the morning. Of course, he started when he was 5. He's now 18, I think, or 19. But he continued that with his mum's help until he was about 14 or 15 years old. His brother, who'd started when he was 7, the 7-year-old just did everything himself from day one. So because they're 11mm gas perm lenses, they're quite easy to handle. They're a lot smaller than a soft, because they're actual lens rather than a bit of a wet cling film. Effectively, they're much easier to apply and remove. So handling is a lot easier with kids.
Yeah, definitely. I think a lot of people, I mean, I've worked with people in the past who sort of said a blanket no to kids in contact lenses, and I think you're just missing out on so many potential,
But it's a definite change, and it's, I think, just the whole kind of myopia epidemic and everything that's going on with that, it's pushed. I bet if you took the average fitting of practices now, you could probably, a typical practice would probably have fitted contact lenses from about 14 or 15 years old now, and I'll bet you that same practice now is fitting them from 11 or 12 years of age. And then you've got folk that are maybe a bit more confident, a bit keener, that are happy doing the younger ones. What's the percentage of ortho-K in other countries? So there was a question that just came up there. In Europe, Holland has the highest, but it's still very low. I think it was 9% estimated for the percentage of ortho-K in Holland. In the Far East, I don't know. I haven't seen information, but certainly it's kind of much more known about, particularly in China. It was actually regulated in China. At one point in China, it got to the point that you could buy lenses on kind of newsagent stand stalls, and then they made it illegal for a while, and then they've reintroduced it with kind of proper regulation around it. So it has been known about for a while. But yeah, the Western world, 1% of patients know about it, which is ridiculous considering it's and I even saw, I get so angry, the social media, an ophthalmologist in a post publicly said, "What is ortho-K?" And I was like, dude, it's one of the optical corrections. We've got specs, we've got contact lenses, and it's kind of a type of contact lens. It'd be like us not knowing about, I don't know, phacoemulsification cataract surgery. I mean, how out of date are you? Oh, unbelievable. And Google it before you put a question up. Google it to find out and go, that's what. Oh.
They're a strange bunch, aren't they, these ophthalmologists sometimes? Do you attempt, I suppose, I'm guessing this is a question about ortho-K, not just topography, but do you attempt it on hyperopes?
No, because this treatment is only you're building. With hyperopes, yes, you can do it. I can design a lens that's going to correct it, but what you end up with is a really small, like nipple area. It's a small area, and it's kind of low power. So one of the slides that I put up in the workshops that we do is, and if you're interested in ortho-K, come to the next one in a couple of weeks' time. I'll go through some examples, but the example I put up is one eye is -13 with a big cell, another eye is -11 with a big cell. Patient comes down to plano effectively in one eye. They're left with a -3, but they always knew they were going to top up with glasses over the top. But in the same way you can do super high prescriptions, they are unicorns. Even that -650 that I put up is a fairly rare patient. So at that point, you've got to fit, 100 patients to find 10 that are actually going to be happy with the quality of vision. And hyperopes is very much the same thing. So from a commercial perspective, no, it doesn't work. Some of the lens manufacturers say they do a plus power, but it's usually up to about a +2. And it's that, from an optical perspective, it just kind of smear your vision. But hyperopes, low hyperopes that are presbyopic will kind of do anything you want. But I think if more appropriate, I would rather sell them a good pair of varifocal specs that they're happy with. They're going to get really great performance with it. And it's not like they're struggling for contact lenses from a lifestyle perspective. There was a question popped up there, what types of patients are suitable? So the patients that I like to fit are up to a -5 correction that they would get with a spherical soft contact lens. That's the ideal patients. So those patients effectively are going to get a full-time correction and they won't need to top up. If you go higher or they've got higher sills, they'll have a bit of a residual prescription that they might need to top up with glasses over the top. So it's looking for patients that are going to be 20 happy. So again, that -13, -11 patient, they were 20 happy, or they were 20 happy, and they had to top up with glasses fairly regularly because of the prescription with one eye.
Perfect, thank you. And I think that answers that other question as well about maximum myopic RX for ortho-K. So you can get it higher, but to get the best results.
I think So let's say I don't recommend really. I've got a few patients at -6, -650. beyond that, it's not really the appropriate correction because we can only change the epithelial cells. It's got nothing to do with lens design. You can make a lens that could correct, in theory, 100 diopters of myopia, but it's the epithelial cell changes that limit it. So of course the treatment zone gets smaller the higher the prescription, and so you've got a really small distance center multifocal prescription with an ad equivalent to your fit. So if you do a -10, you've got a 10 ad. Imagine what the patient's kind of quality of vision could be like.
Yeah.
So
perfect. So essentially, like say, I think they are able to read as well.
Yeah. So again, if you come to the next workshop, there's a video that I put up of patients talking about the experience that they've had. The first guy in there, he's a kind of hard-nosed businessman, and he came to me about age 45, and I thought, he's after a presbyopic correction. He's not really after the night lens. Fitted him and coached him. I was quite open the fact that he would maybe need a bit of help reading. Actually, he's now in his 60s, and he only has a set of +1s he wears occasionally. So he's got a distance center multifocal cornea, and it works in that effectively that way for him. He's got a slight imbalance now in monovision where one eye's like a distance about -0.5. But again, he's 20 happy most of the time, like me, with a compromise because of the flexibility that it gives him. But it's not that kind of reliable. And I also don't, for presbyopes, reduce the optic size because you're not giving an ad like you would do in a bifocal contact lens where it's a measured power. You're just generally making the vision a bit worse than that whole thing. Throw the spherical aberration up, patients might get a softer focus. So I'm not a huge fan of doing that. But patients definitely get a softer introduction to presbyopia, and then you just imbalance the eyes that little bit, and they get glasses to top up to undo the kind of blended monovision.
Excellent. And last one, do you also use the Pentacam or ESP?
Yes, yeah, we can. So they're scleral, designed really for scleral topography. And so the ESP particularly is not great from the point of view of giving you reliable corneal information. So be very diligent if you're using an ESP to get corneal data, because look at the metrics, look at your K readings, look at the readouts you get. You want to have consistent between, say, three captures for each eye. The Pentacam is pretty reliable, but the ESP is not great from a point of view of corneal topography. But yes, yeah.
Yeah, we used to use Pentacam when I used to work in laser surgery, so it was the kind of go-to back then.
So the Pentacam is great from a surgical perspective, and it shows you the back surface. Because another interesting thing, of course, we've got with keratoconics, you've got this front surface cone that you can imagine from the patterns that I put up, but you also have the same thing happening on the back surface of the cornea. So that's quite often when keratoconics, when you put a GP lens on their eye, you trap that tear lens. That tear lens will naturally neutralize 90% of the front surface corneal irregularity, but then you get keratoconic patients that still don't get a good acuity. And it's because the back surface topography is so distorted that it's despite neutralizing the front, there's still a lot coming from the back surface of the cornea. So the Pentacam shows you that back surface as well. But the Pentacam is, again, if you're in a practice where you're going to do a lot of work with laser clinics and your revenue stream is going to come from that, yeah, look at one of those instruments. But if you're looking at just the main revenue so my topographer, after my trial frame, brings in the most amount of revenue from the practice from the point of view of specialist contact lens fitting, more than my OCT, more than any other instrument. So if you're gonna get your revenue from specialist contact lens fitting, my advice would be buy the topographer that's the best for that, which would be the Medman.
Excellent, perfect. Last question: is a large cone topographer better for pediatric population compared to small cone topographer?
No. So it's that trade-off between sort of accuracy from the first fit lenses you're going to get versus something not being quite as close to the patient's eye. So kids are quite excited. They just think they're looking down into looking into a telescope, and you get all the rings. So kids are fine. It's the fidgeting of the kids that's the problem, and that's a good thing with the Medman is it's a video capture, so it automatically just screens the images and picks up better quality images. Whereas if you're having to push a button and fire the topographer and you've got a fidgety kid, that's when it can get quite frustrating. So if you're buying a topographer, it's also worthwhile considering, can you delegate to somebody reliable for them to do it in practice and they become the expert? Because there's definitely a learning curve to getting good quality captures as well. So you need to do it regularly to start with to get over that kind of learning curve.
Perfect, excellent. So I think we've